1 milligram. For prolonged episodes of symptomatic sinus bradycardia, a pacemaker might be the best option.
Sinus arrest. Rate variable depending on the frequency of SA arrest. Rhythm irregular when the SA node does not fire, no P wave. Otherwise regular. P wave usually normal, except absent when the SA does not fire. PR interval normal when the P wave is present. QRS normal except when the SA node fails to fire, no P wave. T wave normal when the SA node fails to fire, QRS absent.
The only abnormality is the occasional failure of the SA node to initiate an impulse with a subsequent missed beat. The significance is that it could be caused by myocardial disease or digitalis toxicity. Occasional arrests are not treated. Frequent episodes require a pacemaker.
Asystole rate none. Rhythm none. P wave occasional to none. PR interval none. QRS none. T wave none.
There is no effective cardiac activity. The significance is that the heartbeat has stopped, so the blood is not circulating. Brain cells will begin to die within 4 to 5 minutes. The treatment? This is a fatal dysrhythmia that requires basic life support, CPR, and advanced cardiac life support. How do you know if CPR is effective in adults? Check the carotid pulse. In infants, check the brachial pulse. In children? It depends on the size of the child. How far should you depress with each compression on an infant? 1/2 to 1 inch.
Atrial fibrillation. Rate atrial rate 400 beats per minute or more. Ventricular rate 100 to 150 beats per minute. Rhythm irregular. P wave no clear P waves. Looks like a jagged isoelectric line. PR interval cannot be measured. QRS normal. T wave not evident.
A limited number of the impulses that originate in the atria are conveyed to the ventricles. The rapid rate increases cardiac workload. The significance is that it's associated with heart disease, COPD, and hyperthyroidism. It can reduce cardiac output. The client is at risk for thrombus formation on the atrial walls. These thrombi can become arterial emboli. Treatment options are synchronized cardioversion, antidysrhythmics like amiodarone, calcium channel or beta-adrenergic blockers, and anticoagulants like heparin and warfarin.
Atrial flutter. Rate atrial 250 to 350 beats per minute. Ventricular 60 to 100 beats per minute. Rhythm atrial regular, ventricular regular or irregular. P wave sawtooth appearance. PR interval cannot be measured. QRS normal. T wave not evident.
A limited number of the impulses that originate in the atria are conveyed to the ventricles. The rapid rate increases cardiac workload and can decrease cardiac output. The significance is that it may be caused by cardiac disease, valvular disease, or digitalis toxicity. Treatment includes synchronized cardioversion and antidysrhythmics like amiodarone or calcium channel or beta-adrenergic blockers.
Nodal or junctional dysrhythmias. First-degree AV block. Second-degree AV block, Wenckebach and Mobitz. Third-degree AV block. First-degree atrioventricular block. Rate normal. Rhythm regular. P wave normal. PR interval longer than 0.20 seconds. QRS normal. T wave normal.
The only abnormality is the prolonged PR interval. The significance is that it results from aging, coronary artery disease, or drug effects like digitalis toxicity. The treatment is to correct the underlying problem. Check serum digitalis levels for toxicity, as you would for sinus arrest.
Second-degree atrioventricular block, Wenckebach, formerly called type 1. Rate, normal atrial rate. Slower ventricular rate. Rhythm, atrial regular. Ventricular irregular. P-wave, normal. PR interval progressively lengthens until a QRS is dropped. QRS, some dropped, missing. T-wave, dropped when QRS is dropped.
The abnormalities are lengthening PR intervals until some QRS complexes are absent. The significance is that the impulses originate in the SA node but have increasing difficulty passing through the AV node. When impulses cannot reach ventricles, a beat is dropped. Multiple drop beats decrease cardiac output. Possible causes include myocardial ischemia or infarction, digitalis toxicity, and electrolyte imbalances. The treatment is to correct the underlying cause, administer atropine or isoproterenol as prescribed, and possibly prepare the client for insertion of a pacemaker.
Second-degree atrioventricular block, Mobitz, formerly called type 2. Rate, regular atrial rate. Ventricular rate may be slower. Rhythm, irregular. P-wave, normal, evenly spaced. PR interval, fixed, consistently normal or longer than normal. QRS may be normal or wide, missing after some P-waves. T-wave, normal, after QRS complexes.
Some impulses are blocked in the AV node, causing a dropped QRS. The significance is that it can follow myocardial infarction or stem from conduction abnormalities. Frequent blocks reduce cardiac output, causing hypotension and bradycardia. The best treatment option for frequent blocks is usually pacemaker insertion.
Third-degree atrioventricular block. Rate, atrial rate exceeds ventricular rate. Ventricular rate below 45 beats per minute. Rhythm, irregular. P-wave, normal. PR interval. P-waves and QRS unrelated. QRS, typically widened. T-wave, normal when following a QRS.
Passage of impulses through the AV node is completely blocked so that the atria beat at the usual SA rate and the ventricles beat independently at an intrinsic rate of 30 to 45 beats per minute. The significance is decreased cardiac output, hypotension, or bradycardia. Treatment is atropine followed by pacemaker insertion. To review, all symptomatic bradycardias are treated the same, either with atropine or pacemaker insertion. Ventricular dysrhythmias include premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation.
Premature ventricular contractions, PVCs. Rate, normal. Rhythm, irregular. P-wave, normal except absent before PVC. PR interval, normal except absent with PVC. QRS, bizarre with PVC, otherwise normal. T-wave, opposite of PVC deflection, normal with other QRS complexes.
An impulse is originating in the ventricle that causes a contraction before an impulse is received through the AV node. The significance is that it can be caused by myocardial ischemia, digitalis toxicity, electrolyte imbalances, stress, and sympathomimetic agents like dopamine. Frequent PVCs decrease cardiac output. Occasional PVCs require no treatment. Frequent or symptomatic PVCs are treated with antidysrhythmic drugs like amiodarone, lidocaine, and procainamide.
Ventricular tachycardia. Rate, ventricular rate 100 to 250 beats per minute. Rhythm, ventricular rhythm usually regular. P-wave, cannot assess. PR interval, none. QRS, wide, bizarre. T-wave, deflected in the opposite direction from QRS.
The pattern is ineffective for maintaining cardiac output. This is a potentially life-threatening dysrhythmia. The significance is that possible causes include cardiac disease,